Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Rohan Yewale, gastroenterologist at Apollo Hospital, Mumbai, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
I'm Dr. Rohan Yewale, consultant gastroenterologist at Apollo Hospitals, Navi Mumbai.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So IBS, or irritable bowel syndrome, is basically diagnosed by the Rome 4 criteria. So Rome 4 criteria suggests that irritable bowel syndrome is the diagnosis of IBS is based on recurrent abdominal pain, which occurs at least 1 day per week over the last 3 months, which is accompanied by at least 2 of the 3 following factors: pain, which is related to defecation, which is associated with change in frequency of stool, or which is associated with change in form or consistency of the stool. The symptom onset should be at least in the prior 6 months, and the criteria should be fulfilled for the last 3 months. For a patient, on the other hand, if I were to explain irritable bowel syndrome, I would simply put it as a disorder of gut function rather than gut structure. So in simple terms, the gut appears structurally normal but does not function rightly. It is a complex interplay between gut motility, visceral hypersensitivity, gut dysbiosis, and the gut-brain axis.
What simple screening questions can a consulting physician ask to suspect IBS?
So a simple screening test for diagnosis of IBS would be applying the Rome 4 criteria as discussed earlier. But one should remember that the Rome 4 criteria should be applied only when alarm symptoms are ruled out, such as weight loss, early satiety, malabsorption, gastrointestinal bleed, and vomiting. So if these symptoms are present, then a more sinister problem such as inflammatory bowel disease, GI malignancies, or malabsorption syndromes need to be ruled out.
How do you differentiate IBS from lactose intolerance, celiac disease, or functional dyspepsia?
So I get questioned about this quite frequently. IBS often overlaps with overlapping conditions such as lactose intolerance, celiac disease, or functional GI disorders. Now coming to lactose intolerance, unlike IBS, lactose intolerance is defined by intolerance only to milk products. And this is a disorder which is typically seen in childhood. Adult onset lactose intolerance is commonly seen as a temporary lactose intolerance which specifically occurs after a bout of a GI infection. Now, lactose intolerance can be diagnosed simply by doing a lactose hydrogen breath test. Coming to celiac disease, the way to distinguish it from irritable bowel syndrome would be in the form of some blood tests such as the serum tissue transglutaminase antibody and endoscopic examination, which suggests certain findings in the duodenum such as scalloping, fissuring, and biopsy, which shows features which are typical for celiac disease. Coming to functional dyspepsia or functional GI disorders, one thing which distinguishes functional diarrhea or functional constipation from IBS is the absence of pain, which is the stereotypical symptom of irritable bowel syndrome. Coming to functional dyspepsia, it is completely a different spectrum of symptoms. Functional dyspepsia is of 2 types: epigastric pain syndrome, postprandial discomfort. So this is completely different from irritable bowel syndrome, where the stereotype symptom is pain, which is accompanied which is related to defecation and is accompanied either by a change in frequency or consistency of stool. So that can be in 3 types of IBS. There can be irritable bowel syndrome, which is constipation predominant. There can be IBS, which is diarrhea predominant. Or there can be IBS which is mixed type, where a patient may have symptoms of both diarrhea as well as constipation at different points of life.
How do you tailor treatment between IBS-D, IBS-C, and mixed IBS?
So, as we discussed earlier, IBS can be of three types. So, IBS, there are three components to management of IBS. One is the most important part would be counseling the patient, and which we'll discuss subsequently. The second would be pharmacotherapy. Now, pharmacotherapy would be based on the symptoms which is predominant in the patient. For a patient who has diarrhea predominant IBS or IBS-D, the line of management would be predominantly symptomatic care for diarrhea. Now, these patients frequently have gastrocolic hurry or urgency or increased stool frequency or reduced stool consistency. For them, agents such as loperamide, bile acid binding agents, or certain tricyclic antidepressants such as amitriptyline are typically used to reduce stool frequency, and certain other agents such as ramosetron are used to reduce the gastrocolic hurry or urgency. On the other hand, if a person has constipation predominant IBS, the management in the form of pharmacotherapy would be in drugs such as psyllium husk or isabgol or fiber supplements, or certain agents which increase the stool bulk such as osmotic laxatives, bulk laxatives, or agents which increase the gut motility such as prucalopride. There are certain newer pharmacotherapy which is available in the market which increase the gut water secretion and increase the fluidity in the gut and increase the propulsion of stool in the gut. And these are medicines such as linaclotide, which act on the chloride channels in the gut, and elobixibat, which increase the bile acid secretion in the gut.
What are some practical ways physicians can build patient trust in IBS treatment?
So the most important part of managing a patient with irritable bowel syndrome is to give them adequate time and to hear out their symptoms. Now, very often I come across patients with IBS who have been labeled to have some anxiety, stress, and psychological problems because on superficially the gut looks completely normal. So these patients come with big files to the OPD. They have been investigated multiple times with different doctors, with different practitioners, with different specialists, and all their reports look normal. The endoscopies are normal, the colonoscopies are normal, the sonographies and other blood tests do not reveal anything significant. And then they often get stigmatized and labeled by family members as having some psychological issues. The most important thing is to give time to these patients, to hear them out, to make them understand about the concept of irritable bowel syndrome, to make them aware and educate them, and to build realistic expectations and to foster a partnership between the physician and the patient. There are certain practical ways in doing so. So IBS patients often have flare-up in symptoms triggered by certain foodstuffs. So I always tell my patients to maintain a food diary. I ask them to note down things which trigger their symptoms so they can avoid them in the future. Also, I often explain them the concept of on and off days. So IBS is a lifelong problem. So the patient is bound to have some on days and some off days where he'll feel miserable about his gut health, his or her gut health. And in such cases, the patient need not panic. They need to see their physicians or the gastroenterologists when they have their flare-up in symptoms, and certain temporary medicines can take care of these flare-ups. So understanding your own gut and being mindful about the triggers, the foods, the stressors can help are some practical ways in which a physician can build trust in a patient with IBS.
What advice do you give to patients for long-term gut health and relapse prevention?
So long-term gut health depends on several factors. First factor would be diet. So patients with irritable bowel syndrome often have bloating as a persistent symptom. And in order to curb this bloating, what I suggest my patients is something called as a low FODMAP diet. FODMAP stands for fermentable oligosaccharides, polysaccharides, monosaccharides, and polyols. These are certain substances in food which cause persistent bloating. So avoiding these substances and replacing them with appropriate substitutes help in reducing the bloating component of IBS. Then another important aspect of diet is to avoid or reduce consumption of processed and ultra processed foods. So what exactly are these processed and ultra processed foods? These are nothing but packaged foods which have certain preservatives added to them to increase the shelf life of these foods, to improve the satiety, palatability, convenience, flavor, and texture of foods. So, not all processed foods are bad. For example, milk, which we consume in our day to day life, is pasteurized and is processed, but it is good for health. You cannot have unpasteurized milk. But at the same time, canned foods, packaged foods like wafers, frozen foods, which have emulsifiers, these are something which are not good for your gut health. Then, after diet, another component for long term gut health is lifestyle. So often our patients with IBS are often stressed out. So simple things like yoga, meditation, adequate sleep help in reducing the stress levels, and thus it is known to affect the gut-brain axis, which in turn affect the symptoms in patients with IBS, and they help in reducing the flare-ups and maintaining the remissions in patients with IBS. The third component would be regular exercise. It is very important to stress upon the importance of regular exercise in patients with IBS. Exercise not only helps in maintaining physical health, it also improves the release of dopamine which is a happy hormone, and makes one feel good about your own gut health. So that is something which I regularly stress upon all my patients with IBS, to have some form of exercise in their daily regime, whether be it some sport activity, whether be it some daily walk or some yoga or basic cycling. And the last component in long-term gut health maintenance would be identifying personal triggers. So there are certain personal triggers which vary from patient to patient, and hence I educate all my patients to maintain a food diet. So there may be certain foodstuffs which cause flare-up and symptoms in certain patients, and they may be tolerated absolutely normally in some other patient, and hence every patient is encouraged in maintaining a food diary so that they can avoid the substances which cause flare-up and symptoms, and thus reduce the dependence on medicines.
The most common mistake you see in IBS management?
Well, the most common mistake which often I see in IBS management is when a patient is hurriedly or mislabeled as IBS. So there is often an overdiagnosis of IBS in our practice. The reason being, a patient who comes, and every patient who walks in your OPD who has constipation, diarrhea, abdominal pain need not be IBS. One should definitely look for alarming features such as weight loss, GI bleed, malabsorption, as there could be more sinister illnesses such as inflammatory bowel disease, GI cancers, or malabsorption syndromes, which I've discussed earlier. So these need to be completely ruled out before labeling a patient as IBS. So the first point, as I said, overdiagnosis or mislabeling. The second mistake we often see in patients with IBS is over investigations or repeated investigations. So once the alarm symptoms are ruled out and a basic celiac disease or inflammatory bowel disease has been ruled out through blood tests such as serum IgA anti-TTG antibody and stool tests such as stool calprotectin, the further course of management would only be directed by the symptoms of the patient. So if an endoscopy and a colonoscopy has been done for a patient, I would not encourage the patient to undergo the same procedures over and over again in a very short span of time, as this just not only adds to the logistic burden but also does not yield anything different in patient management. And the third important mistake which I often see in management of IBS is lack of communication or counseling with the patient. The patient with IBS, as we all know, it's a disorder of the gut-brain axis. So they are very anxious, they're stressed about their condition, and if we don't educate them or create awareness regarding the symptoms and the common food triggers for them, and do not counsel them adequately regarding food, diet, lifestyle, etc., the medicines may not work adequately and they may feel dependent on medicines. So the third most important part would be lack of communication or counseling with the patient.
One myth you'd like to bust about IBS.
So IBS, as I discussed earlier, it's a functional problem. So the gut looks normal but does not function normal. So often patients with IBS have a fear in their mind that whether this may lead to cancer. No, IBS does not lead to cancer, right? And secondly, the one more myth which is commonly faced with patients with IBS or even practitioners who refer patients to gastroenterologists with IBS is whether IBS is same as an IBD. IBD on the other hand is inflammatory bowel disease, which are of two variants, Crohn's disease and ulcerative colitis, which is a completely different disease as compared to irritable bowel syndrome or IBS. IBS is, as we know, a functional problem, whereas IBD is a structural disease where there is gut inflammation, there may be ulcers in the intestine, and the patient may have more alarm features which warrant specific evaluation, and management may be in the form of steroids, immunomodulators, etc.
What's your gut-friendly morning habit?
So the most gut-friendly morning habit would be to consume a glass of warm water as soon as one wakes up in the morning. This, as we all know, improves the gut motility and may lead to a spontaneous bowel movement and improve the urge to pass stool. As we all know, once the bowels are open and one goes to work, he or she may feel more comfortable and the day may be more smoother without abdominal pain, cramps, or discomfort or bloating, which these patients often experience. And the last part, which I cannot emphasize enough, is adoption of either exercise, yoga, or meditation as a part of your daily morning routine.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.